Well, good afternoon. Welcome to Samaritan's Purse International Health Forum. Thank you for joining us today. I'm Dr. Thomas Booby, and I'm the Assistant Director at World Medical Mission, and I'll be your host today. We hope you all participate in the conversation. You can chat with us in the chat box beside the video. Before we begin today, let's open in a word of prayer. Dear Lord, what an amazing opportunity and a unique day we have as we present from different locations across the U.S. Thank you for this chance to bring some information to light about our outreach to this pandemic. Thank you for our speakers. Bless them today as they bring words of wisdom to the audience. In Jesus' name, amen. Well, today we have a very special presentation. This is unlike anything we've had before at SPIHF. This afternoon, we're joined by Dr. Lance Plyler, Dr. Linda Mabula, as well as Ben ONeil here at IHQ to discuss our response to COVID-19 in both New York and Italy. Now, Ben is a medical outreach specialist for Samaritan's Purse International Health Unit, and we're blessed by Ben's assistance with coverage during this outbreak. He's going to kick us off today with the epidemiology of the virus worldwide, as well as other factors to consider. Welcome, Ben.
Thank you so much, Tom. Thank you very much. This is my first time presenting, so thank you for the opportunity. Okay, so in the EPI overview section, we're going to briefly talk about the timeline, the epidemiological factors driving the outbreak, the containment and mitigation strategies being employed to respond to the outbreak. Can we start with the next slide? Yeah, the next one. Thank you. So on this slide, you can see where we started in January. At the end of December, the WHO was notified by China of a cluster of pneumonia of cases of unknown etiology associated with exposure to a wet market in Wuhan, China. When the WHO notified the GORN partners, the Global Outbreak and Alert Response Network partners, of which Samaritan's Purse is a member, of this, we were all a little lost on the significance, to be honest. But within a week, China had sequenced the genes for the virus and identified it as a novel coronavirus related to the SARS virus. Even the significance of the location in Wuhan was a little lost on me. I realized it was a very large area by population, but as you can see from this map, it is the major travel hub for central China. So 1 week later, after we were notified, the first case was outside of China, was already documented in Thailand. China put 60 million people in lockdown in Hubei province, where Wuhan is located. And by the end of January, the WHO had declared the outbreak a public health emergency of international concern. China really did struggle to keep up with containing the outbreak. I think we all remember watching them build 3,000-bed hospitals in 10 days. They mobilized military medics from all over their country into Hubei. They went door to door checking residents for temperatures and symptoms and isolating these people. And this lockdown really only ended recently. The giant spike on that chart is when they realized that their labs could not keep up and they switched to clinical diagnosis. So, you know, it looks like a giant 15,000 person spike, which, you know, kind of ruins the epi curve, but we'll come back to that in a little bit. Next slide. As we continue into February, it's spreading more regionally in Southeast Asia. Philippines reports their first death outside of China. And then you had the Diamond Princess cruise that was docked outside of Japan, had 10 passengers test positive, so they quarantined it. Eventually over 700 people on that ship would be infected. By February 9th, just a week into February, the death toll already surpassed the SARS outbreak of 2002 at 800. And a day later, it surpassed the MERS outbreak, the two related previous coronavirus outbreaks. By February 11th, the WHO gave it its the official name for the disease, COVID-19, standing for Coronavirus Disease 2019. It also named the virus itself SARS coronavirus 2 to kind of signal how closely related it was to the SARS virus genetically. By February 13th, China changed, as you saw on that graph, China was changing how it reported cases to include clinically diagnosed cases as well. And it also released a paper publishing the first 44,000 cases, showing that at least 80% of the patients had mild disease, and that there were increased risks associated with age. Next slide, please. So once we get into March, things start happening quickly. There's an outbreak that happens in the Middle East around Iran, starting in one of the holy cities, and it spurs outbreaks regionally. By March 7th, global cases surpassed 100,000, and 100 countries are now reporting cases. By March 11th, the WHO declares COVID a global pandemic. In March 13th, WHO says that Europe has become the epicenter of the pandemic. So it's actually officially said that it's no longer centered in China. In fact, by the 16th, infections and deaths outside of China surpassed those within. So it really has moved into the global sphere. By March 19th, cases surpassed 200,000, and 3 days later, 300,000. So it's really picking up steam. By March 25th, we have a press conference from the WHO Director General, says that countries, by this time, many countries are going on lockdown mode. And we really start needing to expand our healthcare workforce, create systems in order to find these cases on the community level, increase our production and testing. We're really starting to move into mitigation strategies where we're realizing that not only are we not able to contain it necessarily, but we also may not have the resources to meet the new demands that are put on us. By March 26, cases in the United States surpassed those in China and Italy, making the United States the new epicenter of the pandemic. And by March 28th, China eases lockdown in Wuhan. So that kind of gives you an idea of how long they had to continue suppression. Next slide, please. On April 2nd, so earlier this month, COVID cases surpassed 1 million. And in case you were watching today, we surpassed 2 million today. So just 2 weeks, not even a full 2 weeks later. On April 5th, the African Union estimated 20 million jobs would be lost across Africa. On April 6th, the WHO said that 90% of the world's students are affected by school closures. That's 1.5 billion children. And the death toll in Europe passed 50,000. And then we also started watching for whether or not the epidemic would start shifting into the global south when the seasons change. So we see cases in Africa past 10,000 and 500 deaths earlier this month. So yes, that's kind of bringing us where we are. You can also look at this pie chart, and you might notice that the USA makes up more cases than the bottom 200 reporting countries combined. But I don't want you to lose track of how significant the outbreak is in Europe. if you look at Spain, Italy, France, and Germany, and I think you can actually also add in UK and combine all those, these countries have about 2/3 the population of the US, but they have just as many cases and significantly more deaths than the US. So it has just rocked them very, very hard. But we're also keeping our eye on growing trends elsewhere in many countries that are unable to keep track, either because they just have limited testing capacity, or just their methods of testing are less adequate. Next slide, please. So going forward, like I said, we were watching the Global South. We're also very aware that due to testing limitations and strategies, as well as the national, political, and economic interests, the true number of infected individuals is going to be obscured. We're only seeing the tip of the iceberg. Many countries have been unable or unwilling to test more than the sickest individuals who have been hospitalized or died. Other countries just simply lack lab capacity altogether. Currently, the global case fatality rate is 6.3%. But if we assume it stayed constant at the 2.1% that was originally reported by the WHO in China, which was thought to be an overestimate based upon the lack of catching mild and asymptomatic patients, which could be around 25%, then we would assume that many cases are being missed. In fact, if we keep that 2.1% constant, rather than, and we think that the 118,000 deaths that we have right now are at least accurate, there should be at least 5.3 million cases. But if the true CFR is closer to between 0.5 and 1%, which is what the CDC thinks, then it would be over 10 million infections already. Next slide, please. So this is what we call the EPI Triad. These are usually the characteristics and ways that we look for what is influencing the spread of diseases. So we're gonna look at these elements in the following slides. So next slide, please. So looking at the actual virus, the structure of this virus is an RNA virus in an envelope made of a lipid bilayer with a glycoprotein envelope. These spike proteins, what looks like these little red spikes you see on this image, these connect to the ACE2 receptor on cells, the angiotensin converting enzyme. This was the same thing that the SARS virus connected to. But what we're seeing is that the protein's mutation may have significantly enhanced its binding affinity for ACE2, meaning that you need a lot less virus dosage to be infective. So it's much more contagious, essentially, with a much lower dose. The lipid bilayer, however, it is what we kind of depend on for why soap is so effective in using hand washing to limit the spread of disease. Now, the virus's reproductive number is also a measure of contagiousness. It was estimated by the China CDC and the WHO to be that for every person infected, they'll produce 2.2 secondary infections. However, keep in mind, R0 is not static. It changes as the number of susceptible hosts and interventions that decrease the transmissions are introduced. We'll discuss that as we start talking about the mitigation strategies in the end. Also keep in mind the incubation period. It can be anywhere between 2 and 14 days, at least that's the 95% thresholds, but the average is about 5.2 days. Next slide, please. Okay, so this is the most important thing, the transmission vectors. So we said at the beginning, the first cases were linked to animal to human transmissions at this wet market in Wuhan, but that is of course not the primary driver right now. we think that the DNA of this virus is most closely related to a bat SARS, and it's unclear if there was an intermediate host, if cats or pigs or camels, like other coronaviruses, was an intermediate host. That hasn't been, definitively found yet. It became very quickly apparent that human-to-human transmissions were occurring, especially within family members, with amplifications in clinical settings. As with other respiratory pathogens, transmission is through respiratory droplets from coughing and sneezing. These droplets are either inhaled or land on fomites and touched by others who proceed to pass them into mucous membranes in their faces. Aerosol transmission is possible during medical procedures that could aerosolize the droplets and expose healthcare workers. It is not found to be aerosolized in general, like measles, where it just hangs in the air for times on it. There was one study you might have heard about where they essentially put it in a steel drum, the virus, but that doesn't really replicate how a person sneezes or coughs. That being said, it can be aerosolized in certain procedures. So, using a N95 mask during those procedures is essential. There has been evidence of fecal shedding later in the disease. This lends to the possibility of a fecal oral transmission. That was something that did occur with MERS. I don't know so it is a possibility, but it's not a primary transmission route. So it has been suggested that individuals who remain asymptomatic could also transmit the virus, but this has not been concluded. Because of this, CDC had looked into the value of having the public wear masks in general, and of course they did recommend that. There's still controversy about this because, as we know, neither cloth masks nor just regular surgical masks are able to filter the virus droplets effectively. So their actual ability to protect is limited. What we're hoping for with public masking is that the barrier limits how far, say, an infected person's sneeze or cough can travel. It's not going to completely screen out the virus. Next slide, please. So this shows some of the research done by Korea and Italy. As you can see, in Korea, women and 20 to 29-year-olds were more likely to be found infected with the virus. However, men and elderly were more likely to die. I think this is very important to know because Korea, of all places in the world, has done the best at community surveillance. And as far as I know, they're the ones who found this transmission rate among young people, because they went out and purposefully went out into communities and found, did the drive-through screenings. They went out and contact traced everyone associated with a certain group in a church community. So they did very, very strong contact tracing. And found this age group, spreading it. What we were finding in most countries in the world is that they haven't been able to do this level of contact tracing. So what you're finding is that the groups that with the higher levels of not only deaths and hospitalization but cases are the older groups. But that's because the ways that many different countries are doing screenings is based upon the most upon the worst cases because they're just limited in their capacity to do screenings right now, whether that's because they don't have enough testing capacity or they don't have enough contact tracing capacity. In Italy, the average age of the infected person was in their 60s. The average age of those who died was in the early 80s. Italy has one of the oldest populations in the world. Men in their 70s and 80s make up the majority of deaths. This vulnerability, but also due to limited medical resources. Next slide, please. So in Italy, those who died in Italy had a much higher percentage of chronic disease. And we're finding that everywhere. We found that in China, we're finding that in Italy, we're finding that in the United States. I did not have a slide here yet about race or socioeconomic status, but that's been in the news a lot lately. I just want to make a statement and make it clear that we do not believe that people of any race are more predisposed to being infected because of their race. Now, what we are finding is that in many locations throughout the United States, at least, is that communities of color and communities in poverty are more likely to have some of the socioeconomic status issues that predispose them to worse outcomes, more chronic diseases, more living in multifamily dwelling places, just lower access to health insurance, some of the things that just make you predisposed to poor outcomes. So we don't have data yet coming from our own field, but I'm hoping to be able to add that in a future version of this. Next slide, please. When a pandemic, this slide here is the WHO's pandemic response matrix. When a pandemic moves from phase 4, which is sustained community level outbreaks, to a phase 5 or 6, which are outbreaks in multiple world regions, the strategy shifts from containing the virus to mitigating its impact. And I want to talk about what each of those really means. Those don't prevent you from doing both. You're going to want to do containment and mitigation both within the same country and at the same time in different countries. So let's talk about those in the following slides. So next slide, please. So containment measures. So here's Korea and some of the things they did before. I want to say when you look at slides like this and you're trying to figure out what was most effective, keep in mind that 5 to 6 day incubation period. So even if you perfectly implement a strategy, it's going to take a week for that strategy to start having an impact on the outbreak. And even then, we can't say that the impact has to do specifically with any one strategy that was implemented. So some of the containment measures that Korea used have to do with things like behavioral change. So hand washing, respiratory hygiene, social distancing, initiating active disease surveillance, screening, and contact tracing. We talked about how they followed up with every single contact of each individual and went to their contacts or contacts of contacts. And then self-isolation, medical quarantines, community lockdowns. They put in areas with extra resources, travel and trade restrictions, and then school closures and restricting mass gatherings. So these are all possible containment measures. Next slide. And then mitigation. So mitigation is all about knowing that we can't necessarily stop everyone from getting infected, but what we can try and do is spread it out so that no one is getting, not everyone is getting infected at the same exact time. And the hope is that if everyone's not getting infected at the same time, then you're not going to run out of the resources needed for those people. You're not going to run out of hospital beds. You're not going to run out of healthcare workers. You're not going to run out of ventilators. You're not going to run out of the things people need to get better. And if you run out of those things, your case fatality rate starts going up higher and higher and higher. When if you had spread that out over a longer period of time, everyone could be able to access the things that they need to survive, even if you had the same number of people infected. So some of those mitigation strategies include, again, social distancing, but that could be remote work or distance schools. Medical countermeasures, strengthening ER departments, infection prevention and control, supply chain of PPE and equipment like ICU respirators, or they could be regulatory, loosening regulations to enable quicker development and approval of vaccines and treatments, provision of tools to lessen long-term impacts like economic stabilization or chronic physical and mental disease. Next slide, please. This is by the Resolve to Save Lives organization. It talks about some of the different, in particular, I wanted to focus on the non-pharmaceutical interventions in the middle. Those are things that every country can do, even if they are not able to access what none of us can access at the bottom right now, the particular treatments and vaccines that we're all working on and hoping will come around as they're quickly being developed. But the non-pharmaceutical interventions are things like hand washing, covering coughs, staying home when you're ill, making sure surfaces are routinely cleaned. Those are things that we know can prevent the spread of disease. But all of these are important to do throughout the outbreak. So next slide, please. There was a study recently released by Imperial College. They looked at several of these non-pharmaceutical interventions and their impact on 11 European countries. And what they found is that each one of them were able to reduce the rate of transmissions in countries and bring down that R naught a certain amount, and you can kind of see them stacked on top of each other in that little green chart at the bottom. And of course, some things are kind of brought together. Obviously, the ultimate one being like a total lockdown would kind of encompass all of them, to be fair. But you can see that on average, there was a 64% reduction when you implemented all of these interventions at once in the overall reproduction rates. These, of course, are just estimates, and they do, of course, depend on maintaining them for a significant amount of time. That is the next slide. I believe that's the last of mine. Thank you very much, and take it away, Linda.
Thank you, Ben. I want to remind the viewers to post their questions in the chat box. Dr. Mobula is Assistant Director of Johns Hopkins University and has been serving at our emergency field hospital in New York, and we're very honored to have her join us to discuss our response there. Welcome, Linda.
Thank you, Tom. Next slide, please. I'm going to first start off by talking about the clinical presentation of COVID-19. And I think this is based on data that has come specifically from China. And as Ben mentioned, COVID-19 is a respiratory tract infection caused by a novel virus, SARS coronavirus 2. And when it first emerged, one of the clinical manifestations was it was actually manifesting as a pneumonia of unknown origin. And if you look to the right, there's this graph that shows typical symptoms that individuals present with. And the vast majority of individuals present with the fever. That's about 87%. And that's followed by a dry cough and fever. This doesn't mean that if you don't have a fever, you don't have COVID. I think there are additional symptoms that individuals are presenting with that include cough that's actually productive of sputum. That's only 33% of individuals. Shortness of breath is very common. Myalgias or muscle pain, body aches, a sore throat, a headache. And it's really important to note that COVID-19 symptoms present like flu symptoms or flu-like symptoms. And I think when this first emerged in China, everyone thought it was the flu. And as China saw increased mortality, I think there were lots of questions about the etiology of this disease. So next point I wanted to mention is the fact that most people actually develop a mild or uncomplicated disease course or illness. Only 14% of people develop severe illness that actually require hospitalization and oxygen support, and only 5% require admission to an intensive care unit. Next slide, please. So talking a little bit about testing, I know Ben mentioned this. Many countries have scaled up the amount of testing we're doing, and testing is important to be able to confirm that you have coronavirus, because one of the public health measures that's required to flatten the curve is isolation and contact tracing. So in order to actually be confirmed or to know that you have coronavirus, you have to have a test that confirms this. And the way the specimen is collected is there's a swab that's being done, and that's being done through the nose. So it's a nasopharyngeal swab, or sometimes via your throat. And there's a picture on the right that shows this. This looks very painful and uncomfortable. So the actual test is called polymerase chain reaction, or PCR testing. And as Ben had mentioned, this is an RNA virus. So PCR allows us to detect, COVID-19 RNA. And just wanted to highlight the fact that some people do test negative early on in the course of their illness. And if you're negative, it doesn't mean that you don't have COVID-19. It just means that you're early on in your course and that the viral load is extremely low and it cannot be detected. However, as you get sicker, it's possible that you will test positive. You will likely test positive later as your viral load increases. So in other words, a negative test result does not mean that you are not sick, that you don't have coronavirus, or that you will get sick later. Next slide, please. There are lots of questions, as Ben had mentioned, about whether or not individuals can transmit COVID-19 when they don't have symptoms. And so it is estimated right now, based on data from papers that were published in the Annals of Internal Medicine and the Lancet, as well as from Imperial College, that approximately 30% of people are contagious prior to developing symptoms. And this still needs to be confirmed through larger studies that have a larger sample size. As I had mentioned, the majority of individuals have mild or moderate symptoms, and they might be contagious prior to development of symptoms. But it's also important to know that once your symptoms resolve, you might still be contagious for about 7 to 10 days. However, those with severe symptoms are contagious for a little bit longer after they are discharged from the hospital. And this is a very important public health measure. It has implications on public health because it's important that individuals that are discharged from the hospital remain in isolation for about 7 to 10 days, and they continue to wear a mask because they're potentially still shedding virus. Those with critical symptoms, again, are contagious for longer, and it's very similar to those with severe symptoms. But as I mentioned, this needs to be looked at in larger studies. Next slide, please. I'm going to talk a little bit about treatment. And treatment, again, is a very small component, I think, of the overall public health measures needed to contain coronavirus 19. Those with mild disease actually do not require hospitalization, but however, as I mentioned, because they are still contagious, isolation is necessary to contain the virus. They basically only require supportive care, symptomatic management. Those that have severe and critical disease require hospitalization, and those are individuals that have shortness of breath, and they require oxygen supplementation. So either delivery of oxygen through a nasal cannula, face mask, and as their disease progresses, those with critical disease require mechanical ventilation. This is really important because many countries across the world don't have access to mechanical ventilators. And so it's important to note that about 5% of individuals require mechanical ventilation, but it's important to have access to mechanical ventilation when you do require it. Next slide, please. And this is data, as Ben had mentioned, there has been a lot of data coming from China. And it's really interesting to note that actually having chronic conditions, as Ben had mentioned, such as coronary artery disease, diabetes, asthma, chronic obstructive pulmonary disease, COPD, hypertension, really increases your mortality. And among those that actually had cardiac injury, it's interesting, there were less that actually remain in the hospital. And this is data from Wuhan, and it'll be interesting to see what data emerges from other countries. But I just wanted to highlight the fact for clinical providers, it is really important to be able to control these chronic conditions such as diabetes, such as hypertension, making sure that your patients that have coronary artery disease are actually maintained on their medications, home medications. So we've actually seen a lot of patients come in with uncontrolled diabetes, with uncontrolled hypertension. So one of our goals is to really ensure that these chronic conditions are well controlled during their hospitalization and when they get discharged, because we know that there's a higher degree of mortality when these conditions are not well controlled. Next slide, please. So we have a little bit of data from the US and from Italy. So again, on the left, we're looking at data from the US. So among 178 cases, we're actually seeing more people that have hypertension, obesity, chronic metabolic disease, chronic lung disease, hypertension, cardiovascular disease. And again, if you look at the demographics and the epidemiology of chronic disease in the US, there are more people, younger people that actually have these conditions compared to other countries, which is why in Italy, so we're seeing individuals that are older that are being affected because it's, you're looking at a pyramid. Individuals that are older in Italy are likely to have more chronic disease, whereas in the US, we're seeing a younger population get affected by coronavirus because of the fact that they're actually more prone to these chronic conditions. And this is the case with certain ethnic groups. I think African Americans, Hispanics, Indian Americans, Native Americans are more likely to actually have hypertension and diabetes. And this is linked to diet and exercise, but also access to care. I think Ben mentioned socioeconomic factors. When you don't have access to healthcare, I think you're more prone to actually have uncontrolled disease. So on the right, again, in Italy, we're seeing more hypertension and cardiovascular disease, but this is also linked to the fact that there is an older population. So we're seeing an older population being affected in Italy compared to the US, for example. Next slide. So quickly, investigational therapies. There is currently not a scientifically proven treatment for COVID-19. This is an emerging infectious disease. It just, we had a spillover event from China. And so there is not a scientifically proven treatment. However, there are a couple of scientific trials that are looking at investigating the efficacy of certain therapies. The World Health Organization has a global randomized controlled trial with many countries that are enrolled. And they're looking at multiple investigational drugs, such as remdesivir, for example, that was actually looked at during the Ebola response in DRC. There's a combination of hydroxychloroquine and azithromycin that's being looked at, otherwise known as plaquenil and azithromycin. The antiretroviral lopinavir, ritonavir, otherwise known as Kaletra, is being looked at as well as interferon. And there are additional therapies that are being looked at, such as the use of convalescent plasma to treat COVID-19. Next slide. So there is no vaccine to prevent COVID-19, and looking back at H1N1 in 2009, when that became a global pandemic, there was no vaccine, and it took months to develop a vaccine. Scientists are estimating that it will take at least a year, potentially, to have an FDA-approved vaccine. However, there are 115 vaccine candidates that are being looked at in clinical trials. That's a lot. So out of the 115 vaccines that are being investigated, 73 are currently in the preclinical stage, meaning they're not being tested in humans necessarily. However, 73 are in phase 1, so looking at safety in human beings. Next slide. I think that's it. I'm going to pass it over to Lance.
Thank you so much, Dr. Mabula. Our final speaker is Dr. Lance Plyler. Lance is the Director of World Medical Mission at Samaritan's Purse. He is also coming to you from New York this afternoon and is going to talk to us a little bit about the response there as well as in Italy. Welcome.
Well, thank you so much, Tom. It's a real honor to be with our listening audience and to speak with Ben ONeil and Linda Mabula, my colleagues. I'm very humbled to present with them. Ben, of course, presented from an epidemiological perspective, and Linda just did an excellent job presenting the clinical scenario. And I'm just going to really, my objective is really just to paint a picture and a descriptive of our response as an organization, Samaritan's Purse, to this deadly pandemic. Next slide. So if you'll recall, back in 2014, the just incredibly deadly epidemic in West Africa, it really was a horrible disease in which we were very involved. It really did, though, as an organization, it really did improve our capabilities and capacities. It developed a lot of our different departments, and we've worked corporately together to be able to be far more effective and quick in response. At that time, Franklin Graham, our CEO and president of Samaritan's Purse, said, and I quote, "We run to the fire, we don't run away." And I really just appreciate Mr. Graham's his stance on global disasters and pandemics. I think that it is paramount as Christians that we do run to the fire, and that's what we're doing here during this pandemic. We want to be able to present our medical and total organizational capabilities to help as many people as we can for the sake of the gospel. Next slide. So I just wanted to read this scripture. When I responded to Ebola in 2014, I must have read Psalms 91 every day. And it spoke to me so personally, and it speaks so personally to me now. And I'm going to read just a few verses, but I encourage our listening audience to read the whole chapter. I think God wrote this chapter for Ebola and COVID-19 and so many plagues and pestilence. It says, "You will not fear the terror of night, nor the arrow that flies by day, nor the pestilence that stalks in the darkness, nor the plague that destroys at midday. 1,000 may fall at your side, 10,000 at your right hand, but it will not come near you." And I can't promise that we won't ever become infected. I had a colleague, Dr. Brantley, that became stricken with Ebola. We worried very much for his life. But I really learned as I read this chapter and I went through those events that God has us protected eternally as Christians. And it gives me great confidence when I respond to COVID-19. Next slide, please. So Ben just did a phenomenal job just giving a descriptive, and now unfortunately, the epicenter of this deadly pandemic is none other than New York City. And it's rather ironic in so many ways, because New York City is like one of the major economic and socioeconomic hubs of the world. And yet it has just been paralyzed by this deadly disease. Just today, as we learned, we've surpassed 2 million infections, and the deaths have now exceeded or approached 130,000 worldwide. New York alone has now had approximately 11,000 people succumb to this deadly disease. So it has gripped some of our most highly sophisticated and technological municipalities around the world. Next slide. And you can go to the next slide. I just want to share with you from a personal perspective on the ground, if you will, just this iconic opportunity. You can see there in this picture, just the backdrop of New York City. And then just in front of that, you can see Samaritan's Purse Respiratory Care Unit at our Emergency Field Hospital, right there, and none other than Central Park. I mean, this is just an iconic picture, and an amazing, just an amazing picture. Who would have ever, even 6 months ago, thought that such a reality as this would exist? And again, it's just an amazing opportunity for our organization to respond to this deadly disease that's stricken this city. Next slide. And I just wanted to share with you just some of these pictures. In the backdrop there, you see Mount Sinai Hospital, and they have just been an amazing host. They have been overwhelmed, and they appealed to us for assistance, and we have come. Next slide. And there's another picture. And I just want to say in front of everyone, with regard to our respiratory care unit there with Mount Sinai Hospital, our inclusion criteria is this: if you have COVID-19 disease and you need hospitalization, regardless of any characteristic a patient may have or any affiliation that patient may have, he will be most warmly welcomed into our respiratory care unit. And we will treat everybody exactly the same, with unconditional love and world-class medical care. I'm very honored to serve with Samaritan's Purse, who can deliver this kind of medical expertise. And I'm very proud to serve with them. Next slide. There's an interior picture of one of the units. And just to kind of paint a picture and give you an idea of what it looks like, there's 68 beds in this facility. We have 14 tents. We have critical care or ICU capability and step down capability, as well as general wards. It says 70 plus. It's actually over 100 people there on the field there supporting this endeavor. We do have 10 ventilators, as Dr. Mabula alluded to. The most critically stricken patients do require mechanical ventilation. We have been able to ward off some patients from requiring mechanical ventilation with CPAP therapy. And we do all of this under negative pressure tents. Next slide. I also just want to emphasize that this has really been an organizationally wide effort. There's many departments within Samaritan's Purse. You can see a number of them there. We have North American Ministries, we have projects, we have the BGA, we have World Medical Mission. And really, this has just been an overwhelming pandemic that has required a corporately wide organizational response. And it's really enhanced our capabilities and capacities corporately, and I'm glad to see that. And I think it enhances our ability to respond. Next slide. Really, this endeavor has required many medical personnel. On our team, we have many subspecialties of physicians, including pulmonologists, critical care specialists, internists, family medicine. There's been a whole array of care providers. We've also had great expertise from mid-levels such as PAs and nurse practitioners. Really, honestly, I must humbly admit the nurses are the ones that are provide the greatest hands and feet in terms of clinical work. They've done a phenomenal job. We've really employed pharmacists. EMTs, CNAs have done a phenomenal job in providing ancillary care for our staff. Of course, we've needed respiratory therapists with this disease that really is a predominantly cardiopulmonary disease, although it does have systemic manifestations. There's certainly a lot of rehabilitation that's warranted, and so we've employed physical therapists. There's certainly been a lot of need in terms of laboratory support, and we've had technicians and phlebotomists to provide that care. And I also just want to say, you know, we're looking at the medical staff here, but I really want to give a shout out to our support staff. Our World Medical Mission biomedical technicians, we could never do it without Dave Buckland and his team. We could never do it without the BGA rapid responders, our member care team, just on and on. I could keep going. There's been so many people, so many different departments. Our recruiting efforts back home through HR and again, World Med, our support through the EMIT, and just the whole DART structure, that stands for Disaster Assistance Response Team, that Ken Isaacs has really brought back to our organization. Mr. Isaacs says that the quality of our work is the platform of our witness, and we could never deliver this kind of quality were it not for this array of medical and support staff that I've just described. Next slide. Just wanted to give you a few on the scenes pictures. This is a gentleman, of course, involved in our donning procedure where we have to engage with PPE, personal protective equipment. You cannot be too scrupulous in utilizing proper technique and donning and doffing of this equipment that is a barrier of protection for yourself against this deadly disease. Next slide. We've had opportunity every morning at mealtime. We gather with together for devotions. We pray for the city. We pray for our patients, that we will just provide the most excellence of medical care so that they can get better. Just one thing I just want to share with you that's just been amazing. I will say, I know there's been some controversy about our response there, but I will just say on the ground, New York City has been incredible to Samaritan's Purse. Every meal we have way more than we can eat because of the love and just support of the city. At 7 p.m. every evening, we have this incredible applause across the city. You can hear it echo for miles throughout Central Park. And it's so exhilarating, encouraging when you're tired and you don't think you can go on, excuse me, and you hear the city's applaud. Next slide. Just wanted to give you some anecdotes on the ground of appreciation. This is a note from an anonymous patient that recovered. It says, "Thank you for this hospital and taking care of me." I'm sorry. Nurses and doctors and everybody, thank you. Thank you so much for saving my life. I will never forget. You guys gave me a second life. Thank you for everything. I will always remember. Next slide. Thank you for helping people. Next slide. So I'm drawing to a close here, but it's just, again, I just want to paint the picture. I mean, this is Times Square. We're staying there at a hotel that actually has been offered to us for free. I have no idea what it would cost under normal circumstances, but this is so surreal when we leave in the evening and we come back to our hotel. This is Times Square. Do you notice that there's something missing there? There's no people. It's just so surreal. And again, just an amazing opportunity for us to reach out because New York City needs our help. Next slide. And just, just wanted to share in closing a few of the personal slides, the human touch, the support that we can provide, not just through medical care, but reaching out unconditionally in love and just helping these patients and letting them know that we care regardless of who they are. We care. Next slide. Just a really poignant picture there of hand holding, and that's what our staff represents. I mean, I promise you, you know, they could be somewhere else, but they are called and they're putting their life on the line and they care about these people very much. Next slide. Let's see. I can't read that verse, just one second. It says, this is in Isaiah 53, 5. This was written about 1800 years before Christ came on this earth on our behalf. And it seems like it's just a firsthand account, and it's amazing to me, and it's very inspirational. It says, but he was pierced for our transgressions. He was crushed for our iniquities. The punishment that was brought us peace was, the punishment that brought us peace was on him, and by his wounds we are healed. I certainly could not say it any better than that. He died on our behalf. Next slide. Just want to close out. That's a picture of myself, and that's my son. He's a fourth-year medical student, Jonathan Plyler, and it's great to have the next generation of healthcare providers. They're Christian workers that are willing to put themselves on the front line. He put this PowerPoint presentation together for me as I did not have sufficient time, and I just want to really recognize him and thank him. Next slide. And I will say I couldn't be any prouder than him and all of my children. I think that's it. So I'm going to turn it over to you, Tom, and I'm going to let you entertain questions from the audience.
Thank you, Dr. Plyler. Boy, we have a good number of questions this afternoon. One of the interesting ones, I'll direct this to Dr. Mabula. A couple of questions about prone positioning in our ventilated patients. Is there any data to support the benefit of that? Many questions, if we've seen benefit from that.
So that's a very good question. Just wanted to mention that the large majority of patients that become ventilated actually are in what we call ARDS, acute respiratory distress syndrome. And there are very specific ventilation measures to actually treat those patients. Yes, the answer to your question is yes. Prone position has been shown to help, and there have been a couple of patients at our field hospital that have actually been put in prone position, and we've noticed that their oxygenation has improved quite significantly. We'll be able to potentially give you numbers and more data on this, but this is just anecdotally. Also patients that are not on ventilation, but that are receiving oxygen via nasal cannula or face mask, when they are in prone position or they lie on their sides, have been shown to improve their oxygen saturation.
Great, that's great. Dr. Plyler, I have several questions about need for more medical volunteers or other forms of assistance. Can you talk about that at all?
Yes, thank you, Tom. Yes, I want to just emphasize we could never have responded in the format that we have without medical personnel coming forward. I didn't really elaborate extensively on that, but we have an equally sized outfit going on right now in Italy, as well as New York City. We're also just expanding our clinical capacity in the city too. And so going forward, we're certainly going to need more assistance. Fortunately, as Ben described in his epidemiological presentation, it does look like there's some evidence of plateau, but regardless, this is not going to go away tomorrow. And so we certainly need additional medical personnel of all types of subspecialties. And so if you'll go to the SP website, SamaritansFirst.org, you'll see at the top that there's an appeal for medical professionals. And so we really encourage you to, to click on to that icon and apply and join our force.
Thank you so much. It appears that we're running a bit short on time. I appreciate our speakers so greatly, Dr. Mabula, Dr. Plyler, Ben. Thank you so much for everything you contributed. Remember that CME credit is available for this session. The form and instructions are in your email, and we'll be sending a follow-up email with a link to this recording. If you're not on our email list, you can join the forum at health.samaritanspurse.org and be the first to know about upcoming events. Our next webinar will be Wednesday, May 13. So be sure to join us. Again, thank you very much for all of those who posted questions. I apologize, I could not get to all of them. Thank you so much for joining us today.